The next few lectures will be on antepartum and high-risk antepartum. So when we talk about antepartum, we're talking about prenatal care. And our goals are to promote the healthiest outcomes for our moms and babies and to assure that they have a safe birth for the mother and child by promoting good health habits and reduced risk factors before and during the pregnancy. And so we really want to educate our pregnant women in self-care and provide physical care and preparation for the responsibilities of parenthood. In prenatal visits, ideally we'd like this to begin before conception when we talked earlier about pre-genetic counseling. So that could help reduce some of those risk factors. But normally when people are pregnant, it should begin as soon as the woman thinks she could be pregnant. We hope that she should be taking folic acid by this point because remember we talked back then it's best to take folic acid even before becoming pregnant to prevent those neural tube defects, which can occur very early on in the formation of the fetus in the pregnancy. The recommended schedule for prenatal visits on an uncomplicated pregnancy is that from conception to about 28 weeks, they go once every 4 weeks. Then they'll go more frequently between 29 and 36 weeks. They'll go every 2 to 3 weeks. And then from 36 weeks on, they will meet with their physician weekly. There are signs of pregnancy, and they are divided into different categories, which are presumptive, probable, and positive signs of pregnancy. So what are presumptive signs of pregnancy? First would be amenorrhea, or the absence of a period. Nausea and vomiting can be another. Breast changes, feeling fatigued or drowsy, increased in urination, and what we call quickening. Quickening is the perceived feel of fetal movements. It's not an actual kick, but more like some will describe it as like you're going over a hill in a car, kind of almost like a weird queasy feeling. That's the feeling of quickening. Probable signs can be documented by the practitioner, but not definitive. Whereas presumptive, I always tell my patients that presumptive means these are signs that you can presume you're pregnant, but there's no proof yet. When you get into probable signs, these are some things that a practitioner may be able to observe and document, but they're still not definitive. So one of them is an enlarging uterus with a pregnancy test. Now, why is that not positive? Well, an enlarging uterus can be caused by other things than a pregnancy. It could be caused by fibroids or a tumor. So we have to make sure that it's the pregnancy causing the uterus to enlarge and not anything else. The positive pregnancy test. This has to do with the pregnancy test from home. Although they're almost 100% accurate, there still can be some false positives as well as false negatives in pregnancy tests. So they're not always a positive sign. There's something called a Goodall sign. This is the softening of the uterus and the vagina. So a practitioner would be able to assess this and document it during a pelvic exam. Another sign is called a Chadwick sign. This is where there's a purplish bluish color to the cervix, and this can be a sign as well that there is pregnancy. Hager's sign is the softening of the lower uterine segment. Again, that can be palpated by a practitioner during a pelvic exam. And ballottement is when a fetal part is displaced by a light tap and it rebounds quickly. Positive signs that you are pregnant, so these are the definitive ones, are hearing fetal heart tones either by a Doppler scope or an ultrasound, seeing the fetus outlined on an ultrasound, or the clinician actually feeling the movement of the baby, not just the perceived movement by the mom. So in our prenatal visits, what do? We're going to make sure we take a thorough health history of mom. We do the number and outcomes of past pregnancies she's had. We do a menstrual history, meaning when was her last normal menstrual period. This is what's going to give us her due date when we do what's called a Nagel's rule, and I'll talk about that in a moment. So we're looking for her last menstrual period. Any spotting since her last menstrual period? What is her contraceptive history? Like, does she have an IUD in place? Was she using birth controls prior to this pregnancy? We're going to talk about her history, both medical and surgical. Does she have any chronic conditions we need to know about? Recent infections, surgical procedures, medications that she's on, possibly a teratogen that we need to get her off of medication. Any allergies or any nutritional issues. Any trauma that was involved with her reproductive organs or her pelvis from like a car accident or broken bones. Anything that we need to be aware of. When we talk about her pregnancy history, we're talking about this, what we call a pregnancy outcome history. And this is called gravida and para, and it's divided further into something we call TPAL. So gravida is the number of times that a woman has been pregnant, regardless of the outcome. Meaning that if she was pregnant 5 times and 5 times those pregnancies resulted in miscarriages, she still is pregnant 5 times. That doesn't change. Excuse me, sorry. Okay, go back. Para is the number of deliveries that she has had over 20 weeks gestation. So the amount of those pregnancies that resulted in a delivery after 20 weeks gestation. So if she miscarries before 20 weeks or has an abortion or has other issues that we'll talk about in ectopic pregnancy, for instance, and it doesn't make it to 20 weeks, she does not have a para attached to that. She still has the gravida, but not the para. TPAL is how we break that para down even further. And we say, of those pregnancies, how many resulted in a term delivery, meaning a baby born between 38 and 42 weeks? How many of those pregnancies resulted in a preterm delivery, meaning a baby born between 20 and 37 weeks? Because remember, if it's under 20 weeks, it doesn't count as a para. How many of those pregnancies resulted in an abortion, which is any pregnancy that ends before 20 weeks gestation? That can be spontaneous or elective, or in those other cases like I talked about, ectopic pregnancy, molar pregnancy, things we're going to talk about in the further slides. And how many of those children are now living? So this is an example of how we take a pregnancy history, and this is something you will need to know for your exam, as well as it will be an activity point for you to work on. So Jane is pregnant for the first time. She is now a gravida 1, and then the TPAL is 0000. She carries the pregnancy to term, and the neonate survives. She is now a gravida 1, a term pregnancy 1, 0 preterm, 0 abortion, 1 living. She is now pregnant again. She is a gravida 2, still a para 1, the term 1, 0 preterm, 0 abortion, 1 living. Her second pregnancy ends in an abortion. She is a gravida 2, term 1, preterm 0, abortion 1, living 1. During her third pregnancy, she delivers viable twins. She is a gravida 3, because even though she's pregnant with twins, it's still 1 pregnancy. She's delivered 2 deliveries. She's had 2 deliveries at term. So again, even though it's twins, it's still just 1 pregnancy, 1 delivery. So she's now a gravida 3, a term 2. She's had 0 preterm deliveries, 1 abortion, but she now has 3 living children. So that is how that works. And I know it can get complicated and students often get confused by that. So we'll go over this. We're going to make a practice discussion activity thing during one of your weeks for activity points to kind of help you with that. You'll go over these things as well in clinical. So things to know. Well, we know that the length of pregnancy is 40 weeks or 280 days. So it's actually not 9 months, it's actually 10 months. EDC stands for Estimated Date of Confinement, which is an old term they used to use for pregnancy. They used to call it a term of confinement. But it's your estimated due date or your estimated delivery date. It all means the same thing. In that 40 weeks, there's 3 trimesters, but they are unequal in length. So the first trimester is 0 to 12 weeks. The second trimester is 13 to 27 weeks. And the third is 28 to 40 weeks. So terms you need to know. Gestational age. This is the prenatal age of the fetus calculated from the first day of her last menstrual period. And we do it in weeks, point days. So for example, if someone is pregnant 34 weeks and 5 days, they are considered 34.5 weeks pregnant. Remember, we don't round. They have to complete the weeks. So I would never look at that number and say someone's 35 weeks pregnant. She's technically 34 weeks pregnant until she completes all 7 of those days. If she's a multigravida, that means she's been pregnant many times, multi-pregnancies. If she is a multipara, or what is often referred to as a multip, she has had many deliveries. Because remember, you can have many pregnancies that perhaps ended in miscarriages and you've never delivered those infants. You can be a grand multipara, which is someone who's had more than 5 deliveries. A prima gravida is someone who's pregnant for the first time. A primipara, or referred to as a primip, is someone who's had their first delivery. A nulla gravida is someone who's never been pregnant. And a nullipara is someone who's never delivered. In that prenatal visit, we also get a family history. We talk about genetic history, chronic diseases, history of the mother and the father, any drug or alcohol abuse, any genetic or blood incompatibility issues that we need to know about, any psychological history, lifestyle, cultural practices, or maybe a concern of ability to parent. So in prenatal visits, we also do a complete history with a physical. So we do a baseline weight with vital signs. We do a nutritional status, physical or social problems. We'll do lab work. We'll do a pelvic exam to evaluate the size and condition of the pelvis. We'll assess for signs of pregnancy. In those other signs I talked about, the Goodall sign, the Chadwick sign, and that's in a lithotomy position in stirrups. We want to make sure we offer her the ability to void prior to a pelvic exam to make it more comfortable for herself, and obviously using clean or sterile gloves, a lubricant, and a speculum. When we talk about EDC, or her due date, we can use something called a Nagel's rule, and this is used to determine the EDC in a non-invasive method by just estimating the date of birth based on her last menstrual period. Accurate use of the Nagel's rule requires that a woman has a regular 28-day menstrual cycle. So to calculate the estimated due date or date of confinement based on her last menstrual period, you add 7 days to the first day of her last menstrual period. You then subtract 3 months and then add the year if necessary. So for example, if a woman's last menstrual period was November 20th of 2019, you would add 7 days to that, which would give you November 27th of 2019. Then you would subtract 3 months. That would give you August 27th of 2020. That would be her due date, August 27th of 2020. This is a method that we use. This is just a little wheel that we use that can kind of place the arrow on the last menstrual period, and that then it can calculate your due date that way as well, using that same math rule. So more into our prenatal visits, we want to review for any known or new risk factors. We continually do blood pressure and weight checks. We'll dip the urine for things like protein, glucose, and ketones. We'll measure fundal height to make sure that the pregnancy is measuring accurately. We can do something called a Leopold's maneuver, which is where we can feel the back of the baby's spine, the head, and the rump, and we can determine sometimes approximately a guesstimate of how big this baby is, as well as what position it's in. And we could do a fetal heart rate by a Doppler as early as about 10 weeks, and with a fetoscope about approximately 20 weeks. During that fundal height measurement, again, remember we measure from the top of the symphysis pubis, and by the end of the 12 weeks, it's palpable just above there. By the 20th week, it should be level with the umbilicus, and by 36 weeks, it should touch the xiphoid process. So this is just a visual of how that uterus grows and how we're able to measure. Again, remember, fundal height, fundus is the top of that uterus, so that's what we're measuring based on that picture to estimate about how far along that pregnancy is. And remember, the measurement of the fundal height only correlates with the gestation of the pregnancy between 18 and 32 weeks. We will do fetal heart rate monitoring. At term, we know that the heart rate should be between about 110 and 160 beats per minute, that the fetal heart rate will drop in the late stages of pregnancy, and that the fetal heart rate out of this range would need to be reported and possibly evaluated further. In the first trimester, we will do a bunch of laboratory tests. We'll do a CBC, a basic metabolic panel, we'll get her blood type and HIV status, her rubella status, whether she's immune or not. We could do a cystic fibrosis screening, a hepatitis B screening. We can screen for any sexually transmitted diseases like HIV, gonorrhea, chlamydia, or syphilis. In the second trimester, we can do something called a triple or a quad screen, and I'll go explain these as we go further. This is done about 16 to 18 weeks. An ultrasound may be done around 20 weeks. There is something called a blood glucose screen for gestational diabetes. That's usually done between 24 and 28 weeks. If an amniocentesis is indicated, and keep in mind it's not a routine thing done in all pregnancies because of its risk factors, but if it is indicated for other reasons, that could be done between 16 and 20 weeks. We'll always get a hematocrit and a hemoglobin level, specifically at the early stages of pregnancy and at the end of pregnancy. We'll do an administration of RhoGAM at 28 weeks if the mother is Rh negative and there's an antibody screen that's positive, and we can get a fundal height. So what are we talking about with Rh factor? If the mother is Rh negative and a father is Rh positive, the fetus can inherit the Rh factor from the father, making that fetus now an Rh positive blood type. Well, the Rh negative mom can develop antibodies to that Rh positive baby. And when the blood mixes, either during pregnancy at times or delivery for sure, the body will respond by making antibodies to the Rh antigens in baby's blood. And this becomes sensitized, and the antibodies can cross that placenta and then attack the baby's blood. The breakdown of fetus's red blood cells occurs. This can cause, in the infant, anemia, serious illness, brain damage, hydrops fetalis, or any other death in the fetus or the newborn. So sensitization can occur anytime the fetus's blood mixes with the mother's blood. So keep in mind a couple factors. One, when a mom is pregnant with the baby, we do not know what the baby's blood type is. However, we know that if mom is negative, there is a potential that she has a positive baby. So we always treat mom with RhoGAM regardless, because we don't know what baby is. We do it as a protective measure. Also keep in mind that if the father does know his blood type, which often people don't, there is a bigger chance that the baby will be positive, because the babies often take their Rh factor from the father. And lastly, we want to make sure that we are doing this test during the pregnancy, administering the RhoGAM during the pregnancy, and then we will test again after she delivers both the baby's blood type and mom's antibodies to see if mom needs a second dose. So RhoGAM, what is RhoGAM? This is Rho-D immunoglobulin, and we call it RhoGAM for short. It's a sterilized solution made from human blood, so it is a blood product that is given to Rh negative mothers. This prevents the immune response that their body wants to normally do against an Rh positive baby. So it's a blocking antibody. And it's really fairly new in the fact that it was just developed and used since 1968. So we give it in pregnancy. We give it whenever bleeding occurs at any time during the pregnancy if we're worried that mom's Rh negative blood could mix with her fetus. An example of that would be if she had a car accident, or if she had something to go wrong with her placenta, or if she had a miscarriage. Anytime blood could mix. Procedures that increase the chance of blood traversing the placenta would be like an amniocentesis or a chorionic villi sampling test. If she has an ectopic pregnancy, a miscarriage, or significant trauma to the abdomen. At 28 weeks is the increased likelihood of the baby's blood crossing into mom's blood in late third trimester. So we give this RhoGAM at about 28 weeks. RhoGAM lasts for 12 weeks, which would be the remainder of the pregnancy. At delivery, the baby's blood type is then determined. We can now test the baby's blood from their umbilical cord once they're born. If the baby's blood type is Rh negative, then mom doesn't need another RhoGAM shot because there was no incompatibility. If we do an indirect Coombs test and mom has already developed some of these antibodies, we know that that baby was a different blood type, and so we know that there was some incompatibility there. So another RhoGAM injection is indicated for our mom to be given within 72 hours after she delivers to protect future pregnancies, meaning that once that baby's delivered, the blood has mixed, mom's blood type is starting to make antibodies again. That is tested through that indirect Coombs test. Those antibodies are kind of lying in wait and staying there. So the next time she gets pregnant, even very early on, if that fetus is a positive blood type, those antibodies are already sitting in mom's blood waiting to attack that new fetus's blood and could potentially cause life-threatening deformities and can cause death. So we will protect any future pregnancies that the mom may have by giving her a second shot of RhoGAM within those first 72 hours. We usually do it on the postpartum floor to protect her in case she were ever to get pregnant again. That blocks those antibodies from attacking future fetuses. In the third trimester, we'll do something called a Group B streptococcus screening. That's done around 35 to 37 weeks. We will swab the rectum and the vagina, or they can do a urine test, and that will tell us if mom has that normal flora bacteria at that time. If she does, we need to treat mom with antibiotics during her labor as to prevent the baby from contracting this and potentially getting sick. We could also do another ultrasound if needed in the third trimester, and we could do the Leopold's maneuver where again we're assessing fetal size and position. There are physiological adaptations during pregnancy, as you can imagine, so we're going to go over those now. First, the uterus. The uterus undergoes the most dramatic changes. It increases from 2 ounces to 2.2 pounds, or 5,000 milliliters. And it reaches the xiphoid process at term. So remember we said it's like 20 times the size of what it is regularly when you're not pregnant. The cervix will undergo changes. It'll soften and the color will change. Remember we talked about the Chadwick sign. A mucus plug will form, and this protects the fetus from invasion of organisms and infection. And when labor occurs, that cervix will thin and dilate, and that mucus plug will be expelled. The vagina will undergo changes. There'll be blood supply increases and changes in color, and we may have some spotting noted. Connective tissue will soften, smooth muscle will hypertrophy, and the vaginal vault will lengthen. Mucosa will thicken, secretions will increase, and there will be more acidic and more higher in glycogen. And intercourse can continue as long as the pregnancy is progressing normally. The breast will undergo changes because of the estrogen and the progesterone, which is preparing the breast for lactation. Breast can become highly vascular. There we'll see an enlargement of the breast, the nipples, the areola, and the Montgomery follicles, and the Montgomery tubules. In the cardiovascular system, we're talking about the muscles of the heart can enlarge slightly. The heart is pushed upward and toward the left, so it's actually displaced slightly by the pregnancy. Cardiac output is going to increase up to 50% because you're not only circulating blood for yourself, you're doing it for the fetus as well. This causes the heart rate to rise to about 10 to 20 beats per minute higher than your normal. Blood changes. There's total vascular blood volume will increase by 40 to 60%. This will allow adequate perfusion to the placenta and then onto the fetus. Red blood cell volume will increase by 20 to 30%. Plasma volume will increase by 40 to 60%. And there's a dilution in the hemoglobin concentration. Well, remember we talked before about physiological anemia of pregnancy. That's when that's occurring. In the supine position, we want to make sure that remember we talked about how that can compress the fetus against the spine, which compresses that aortic valve. So we want to make sure that we are lying or telling our patients to lie on the side. We want to prevent orthostatic hypotension by lying on your side. We want to look at things about anemia, dependent edema, which can happen with prolonged standing or sitting. So we want to make sure we tell our moms to elevate their legs when they're sitting. They're at higher risk for varicosities due to the dependent edema and the extra platelets and blood clotting mechanisms in the blood and the thicker viscous blood that happens during pregnancy. So we encourage our moms to wear support hose and to avoid crossing their legs when sitting. This is another picture of how we're telling our moms to avoid laying on the back and to try to stay onto a side lying position. The respiratory system will undergo some changes. Their oxygen consumption of the mom will increase by 15 to 20%. Again, she's responsible for oxygenating the baby. The pregnant woman will breathe more deeply, and her respiratory rate will increase slightly because of this. It does decrease a little bit when lightning occurs, when the fetus descends into the pelvis for birth. So lightning is when the fetus starts to descend in that birth canal, which will kind of alleviate a little bit of the discomfort of taking a full breath, so her breathing can decrease a little bit more her respiratory rate. The uterus will exert upward and put pressure on the diaphragm, so this can often make mom feel short of breath, and her rib cage will flatten to compensate for this. Edema in the nose, pharynx, larynx, trachea, and bronchi are all common. These can cause conditions like nasal or sinus stuffiness. She can have changes in her voice, or she can start to have epistasis, which is when the nose starts to bleed. They could have eardrum and eustachian tube issues where they have a feeling of fullness, and sometimes it can impair hearing slightly and temporarily or cause some earaches. In the renal system, the kidneys will have to handle both the waste of mom and fetus, so they're going to have to work harder. So her glomerular filtration rate will increase by 50%. What also affects the excretion of glucose, so it's causing glucose to spill into the urine. It's also causing mild proteinuria, which is also common in pregnancy as protein spills into the urine. And she's going to have increased frequency and urgency in urination. Her gastrointestinal system will be affected. She can experience nausea and vomiting, which is why we educate our moms to eat small, frequent meals like dry toast or fruit. She may need medication for this. Some of our moms need to go on Zofran or Phenergan or Reglan. She'll have increased salivation, bleeding gums, and increased flatulence. She can have heartburn, which is a very common side effect of pregnancy. So we educate our moms to remain upright for 30 to 45 minutes after they eat. We tell them to try avoid eating right before bed. She can experience constipation because the GI system can slow down a little bit with the pregnancy. So we encourage her to eat high fiber foods and increase her fluids. And this constipation, as well as all the dependent edema and pressure, can cause hemorrhoids. The musculoskeletal system is affected. There's a hormone called relaxin, along with progesterone and estrogen, causes the joints to relax and stretch, and that also affects the pubic bones and allows them to stretch. This is what gives mom her waddling pregnancy gait, which is that unsteadiness later in pregnancy where the moms have a little bit of that waddle. She can develop something called lordosis, which is the curvature of the lower part of the spine as her center of gravity is now shifted. It corrects the posture and body mechanics and can reduce lower back pain caused by this. And her abdominal wall can develop something called diastasis rectus. So diastasis rectus is in this picture where those abdominal muscles separate. So this can occur due to the gravidity of the pregnancy, the heaviness of it. Those muscles can come back to normal after she delivers with a little bit of physical therapy and exercise. It doesn't usually cause a lot of pain, but it's very evident if mom were to do a crunch-like formation, you can actually see those muscles separate. Her integumentary system will be affected. She can develop stria, which is stretch marks, linea nigra, which is a vertical dark line that can run down the center of her body. It's usually due to the hormones from pregnancy that's causing this darkening of the skin. It's also the reason why the areola and the nipples may appear darker during pregnancy. She could develop a skin hyperpigmentation called chloasma, which is what we call the mask of pregnancy because it's darker skin around the eyes and the nose, which looks like you're wearing a mask. That too will go away after the pregnancy. She could be more prone to acne or spider nevi and sweating. So this is an example of stretch marks on the one side, on the left side, the stria, and the second picture is an example of the linea nigra, just that dark line from the pregnancy hormones. Again, both would go away after pregnancy. The endocrine system is affected. The thyroid gland will enlarge. The pituitary gland, oxygen is released from this posterior pituitary, and the pancreas, where insulin secretion works on the supply versus demand mode in this case. In the neurological system, she may develop headaches or syncope. So those are all those systems are affected. So obviously a lot of education to our pregnant moms. We're going to troubleshoot these things. We're going to look for these things in our prenatal visits with our new moms, and we're going to give them, heads up on what they can expect and ways that they can kind of alleviate some of the pains that come along with pregnancy. So we also want to make sure we're giving them proper nutrition advice during pregnancy. Healthy eating will enable the optimal gestational weight. So we want to make sure that we're recommending prenatal vitamins, that we're following guidelines. We're telling her to increase fruits and vegetable intake, to reduce the amount of intake of saturated fats, to avoid alcoholic beverages, to at least to eat about no more than 2 servings of fish weekly, to consume at least 2 quarts of water a day, And we only really need no more than 300 calories more than average in the second and the third trimester. So there really is no reason for mom to overeat. So we want to avoid using pregnancy as an excuse to eat more. And then pregnant women may have something called pica. Pica is a practice of craving substances with little or no nutritional value. Now, this could occur when you're not pregnant, but it's very common in pregnancy. So most pregnancy and pica related cravings involve non-food substances such as like dirt or chalk, which you're thinking that's odd. So the common pica pregnancy cravings could be any of those listed in that blue chart, clay or charcoal or dirt or powder. It's an unusual craving of a non-food or non-normal substance due to a mineral and vitamin imbalance that occurs because of the pregnancy. When she's eating healthy and she's taking her prenatal vitamins, this doesn't usually occur, but it can for those who have bad nutritional practices. So the factors in food affecting dietary intake during pregnancy can also lead to this, for the fact that she may have differences in taste and smell changes during the pregnancy. Something that she may have liked when she wasn't pregnant, she can't smell anymore because it makes her sick or nauseous. One of those examples would be coffee. It can cause these other issues to consider as well. As far as pica goes, as long as the patient is getting balanced as far as her nutrition and her vitamins, and as long as what she's ingesting is in small amounts and not causing any issues for high risk, they'll let them go. So again, if mom wants to eat a little cornstarch or a little toothpaste, it's not going to be detrimental. However, if it gets to the point where she's really ingesting a lot of these things, then she will be hospitalized in order to correct the imbalance of what's going on as far as her nutrition goes. She needs adequate intake of protein, iron, calcium, and vitamin D. We know that folic acid is super important, so we recommend her to take up to 1 month prior to pregnancy to prevent those neural tube defects. We want to make sure that she's getting DHA and lots of fluids. So the pattern of weight gain during pregnancy is usually about 4 to 4.5 pounds are gained during that first trimester, just under about a pound a week for the remainder of the pregnancy from there on. Weight gain recommendations, again, can change between normal to underweight to overweight or obese, how much weight you should gain based on what you were before you were pregnant. And women with multiple fetuses can gain more than what's recommended and usually do. So the distribution of weight, where does all this weight go? Well, the baby takes about an average, again, about 7.5 pounds of that. The uterus, because of its, changing in size to 20 times the normal size, will now be about 2 pounds. The placenta itself weighs about 1.5 pounds. Amniotic fluid weighs about 2 pounds. The breasts become bigger with more volume, so they weigh about an extra 2 pounds. Blood volume itself has an extra 4 pounds of weight to it. Extravascular fluids do another 4 pounds, and then maternal reserves of fat are 7 pounds. So that's about where that pregnancy weight is distributed. So again, we talked about this a little bit earlier, but just to go over it again, foods to avoid during her pregnancy would be raw meat, rare meat, deli meats, fish that has a high content of mercury, shark, swordfish, king mackerel, tuna. It's lower in mercury, but still need to limit the amount you do. Raw shellfish like clams or mussels. Anything like with raw eggs, Caesar dressing, hollandaise sauce, custards, any unwashed fruits or vegetables, any soft cheeses like brie, feta, gorgonzola, or some Mexican cheeses where they're not made with pasteurized milk. So then, in addition to physiological changes that are occurring to mom, there's also psychological changes and adaptations that need to be made during pregnancy. So for the first trimester, often moms will feel a disbelief about the pregnancy or not feel like it's real, sometimes even being a little ambivalent. She's still focusing on herself and her new physical sensations and changes that are occurring to her body. Mood swings can be very common. We just reassure partner that these are normal and that they can be supportive during this time. During the second trimester, the fetus becomes more real. It's a more stable time. She'll eat better. She allows to be pampered or being taken care of. This is the best time for teaching of lifelong healthy habits. If she's starting to eat really good nutritious food, this is the time to say to her, carry this on throughout the pregnancy and then thereafter. During the third trimester, she's starting to get a little bit more irritable. She can feel kind of big or ugly. She can have mood swings that return due to the hormone changes. Now she's starting to get a little anxious or worried about the challenges of labor ahead. This is where they're taking childbirth classes. They're beginning to become more physically and mentally fatigued. It just requires more energy to do things at this size. And she can start to feel very anxious. Another thing to think about is when pregnancy occurs in times of adolescence. So the pregnant adolescent has to cope with two of life's most stress-laden transitions of their life, adolescence and parenthood. And they have to do it at the same time. So sometimes they'll deny the pregnancy, try to hide it for either fear of their parents, their partner's reaction, or acceptance by others. And they're also at greater risk for iron deficiency anemia since teenage girls are already at risk for that. And they're also at risk for drug and alcohol use that may be involved. So did you know that the brain is not fully developed until the age of 25? So this is another thing to consider when you're trying to educate an adolescent mother, that how much they're fully grasping and able to make good decisions. And teens are most influenced by their friends more than anything else, more than their doctors, their nurses, their parents, anything they read. It's usually their friends who they're more willing to listen to and be influenced by. So keep that in mind as well as you're trying to educate the adolescent mom. So different discomforts of pregnancy that can occur. There's common discomforts throughout the whole pregnancy, and we're going to break them down during the trimesters. So in the first trimester, we talked about there's going to be urinary frequency. They're going to feel fatigued, oftentimes nauseous or vomiting. This is that early stages of morning sickness. They're going to have breast tenderness due to the changes. They may feel constipated or have increased gas. And this is where that nasal congestion can come in, the bleeding gums, the extra salivation, and then so many unusual cravings can occur during this time. So our nursing recommendations, if you were teaching moms, are to encourage them to get 8 to 10 hours of sleep at night, nap during the day when able. There's relaxation techniques, meditation. For nausea and vomiting, we educate our moms to eat small meals to maintain their blood glucose at a consistent level throughout the day. And we recommend them eating kind of dry, bland things like toast or crackers, specifically before getting out of bed to alleviate that morning sickness. We tell them to avoid fried, greasy, or spicy foods, or anything with such strong odors. We want to make sure that they're drinking fluid consistently, but ideally between meals instead of with meals to avoid that fullness feeling. If accompanied by fever, pain, or weight loss, we want to make sure that they are seeking medical attention. The common discomforts of the second trimester could be that now the backache, remember the center of gravity is changing, leg cramps or groin pain due to the extra pressure. Varicosities can occur at this time, as well as hemorrhoids, and she may notice more flatulence with bloating as well. Our recommendations are she can use over-the-counter aesthetic ointments for the hemorrhoids, witch hazel pads, using sitz baths. For leg cramps, we want to make sure that we give her some of these exercises where it could be best relieved by a dorsal flexion of the foot or standing with the affected area flat foot on the floor. Also, diet should be in consideration as women need to get enough calcium and potassium to try to avoid those leg cramps. In the third trimester, because of the increased uterus now pushing on that diaphragm, she may notice a shortness of breath or difficulty in breathing. There's going to be a lot of dependent edema, specifically in her legs, feet, and she'll have some in her hands and her face. She may notice increased heartburn or indigestion, as there's not a lot of room in the abdomen, and she may start to notice those Braxton Hicks contractions we talked about, where that uterus is starting to contract and get you ready for that delivery. So nursing recommendations will instruct mom again to eat those small meals instead of a big full meal that can cause issues with indigestion and heartburn. She can take over-the-counter Tums to provide relief. Antacids with high sodium content should be avoided, though, because of the fluid retention, so we'll tell her to avoid things like Alka-Seltzer. Fluids can overstretch the stomach and may precipitate the reflux when she's lying down, so that's why we instruct her to sit up after meals for at least 30 minutes before lying back down. We want to make sure that she tries to avoid those greasy and gas-forming foods and avoid caffeinated beverages and orange juice, which can stimulate the acid formation in the stomach, causing more heartburn. We want to promote self-care for mom. Personal hygiene, We want to tell her to avoid hot tubs and saunas because that can get too warm. Make sure she's keeping up with dental care, specifically when she's having issues with the bleeding gums. Breast care, we educate them on proper and safe sexual activity. Mild to moderate exercise. We educate them on travel. Travel is important that they understand that they really shouldn't be, or they should try to avoid travel in the third trimester, specifically on an airplane. One, because they're at risk for delivering at that time. So you certainly don't want to be out of state without your medical records, without your doctor, and then go into labor. The other reason is that on an airplane, you are more likely to develop a blood clot from the lack of walking up and down and moving around since you're sitting for long periods of time, especially if it's a long flight. And in that late stage of pregnancy, you're particularly vulnerable for blood clots in the legs. So you want to avoid that if you can. And then again, childbirth education with classes, pamphlets, any other things we can kind of promote for them. Exercise in pregnancy. In general, moderate exercise for several times a week from about the 8th week through delivery is advised during pregnancy and safe. However, you want to avoid vigorous exercise. And again, this can be determined on whether mom was an athlete or a runner or whatever she was doing before she was pregnant. She may be able to handle more than someone else. So you certainly don't want to advise starting a marathon or running more than you ever did now that you're pregnant. And the goal really is to maintain fitness, obviously not to lose weight, but just to stay healthy. And again, the travel we talked about. So travel is safe, we tell our moms, up to about 30 weeks. So a copy of your obstetric records should be taken with you in case you do deliver outside of your home. You want to make sure you're wearing comfortable, unrestricted clothing, drinking plenty of water, practicing good hand hygiene to prevent infection. And if you do have to fly, request a seat with greater legroom and try to get up and walk frequently, even if it's just to and from the bathroom or down the aisles, as much as you can to increase that risk of that thrombosis. So now we're going to move on to antepartum tests. So there's lots of tests we do during pregnancy. And we're going to kind of go over those one by one. So the fetal heart rate, we're always going to test to see if we can hear a fetal heart rate and an ultrasound. We can do something called a kick count, where we know mom should feel about 10 kicks within about 2 hours to make sure that the baby's moving adequately. We can do a test called an alpha-fetoprotein test, which alpha-fetoprotein is something that's made in the fetus's liver. And when you test that, if increased levels are noted, that can be associated with neural tube defects, abdominal wall disorders, and spina bifida. And if there are decreased levels of alpha-fetoprotein, that can be associated with Down syndrome. So this is just an example of an ultrasound. So these are just different ways that we will do this. So just to go over some of those tests we were talking about, we can do these done between 15 and 17 weeks gestation for that alpha-fetoprotein test. And again, we test the levels, we check these levels in maternal blood. However, the alpha-fetoprotein is made in the fetal liver. So other things to know for the ultrasound, that we can do this for dating, if we can measure the fetus to kind of get an idea of a due date that we can use along with our dating that we use with the last menstrual period. We can also look at the size of the infant, the position of the infant, the sex of the infant, as well as the amount of amniotic fluid around the infant. So amniotic fluid index should be between about 8 and 24 centimeters of pocketed fluid. So if we go back one, it would be these pockets of area. They actually measure all around the baby to get a general count of how much fluid is around the baby. So anything less than 5 centimeters of fluid is called oligohydramnios, which means low fluid, and anything above 24 centimeters would be considered polyhydramnios, which means too much fluid. So amniotic fluid volume can range anywhere between 800 and 1,000 milliliters. And so this is just oligo and polyhydramnios divided by the actual milliliters as opposed to the centimeters, just to get a better idea. Another test we can do is chorionic villi sampling, which obtains a small part of the developing placenta. Again, you have to wait till about 10 to 12 weeks when the placenta develops to detect any chromosomal abnormalities. Not a routine test, but can be done if a genetic abnormality or chromosomal abnormality is suspected. Another test that can be done is the amniocentesis we talked about. This is where you obtain a sample of the amniotic fluid. And again, best to do it between about 11 and 17 weeks, 18 weeks, somewhere around that, to detect any genetic disorders, metabolic disorders, and we can also use it to determine fetal lung maturity if we feel that we may need to deliver this baby early for maybe a health condition on mom. We can test the fetal lung maturity to see if it's safe to do so, if the baby's got enough surfactant to be delivered. Another test we can do is something called a non-stress test. This is a fetal monitor that is attached to the mom to detect fetal heart accelerations and reactivity. When there are 2 or more fetal heart rate accelerations, so the heart rate goes above, so these are these accelerations right here, this one, this one, this one. So this is the normal fetal heart rate, and accelerations is when it exceeds above the normal baseline and returns to baseline. And in order for it to be considered an acceleration, it has to go up by 15 beats, and it has to last for at least 15 seconds in order to be considered an approved acceleration. And we look this strip over in a 20-minute period, and mom should have at least 2 of those accelerations or increases for us to say that the baby is doing well. The fetal lung maturity that we talked about, that's called the lecithin sphingomyelin ratio, or what we just call the LS ratio. It's performed via the amniocentesis, and we can determine fetal lung maturity by this. So surfactant is a mixture of lipids and proteins and glycoproteins, which is in this LNS. So when the lecithin starts increasing in comparison with the sphingomyelin, it indicates that there's more surfactant in the lungs. So we're actually looking for a ratio. So if the LS ratio of 2 or more, that means there's a low risk of the infant having respiratory distress syndrome because we know the baby has, or the fetus has enough surfactant in the lungs. And we remember from before, surfactant is what's allowing that alveoli to expand and to keep it from sticking together. If the LS ratio is 1.5 or lower, we know the infant is at higher risk for respiratory distress if born at this time. So sometimes this can help a physician determine whether or not to take the baby early or not. And again, in those cases, it would be weighing the risks and benefits if mom's health was at risk and we needed to take this infant earlier. Another test we can do is something called a biophysical profile. It's an ultrasound assessment of fetal status used alongside the non-stress test. And this just is to ensure that the fetus is receiving enough oxygen and the placenta is operating efficiently. So there's 5 parameters of the fetal activity. We look at the fetal heart rate during this ultrasound, the fetal breathing movements. So although a fetus doesn't necessarily breathe oxygen and use their lungs, they do make a fetal breathing movement, usually no more than about 2 times an hour, but it's just a way that they do to kind of stretch that diaphragm, even though oxygen is not coming in. So we look for those movements. We look for gross fetal movements of the arms and legs. We look for the fetal tone. Remember, the more term they are, the more they should be in that frog-like position. So we want to make sure that they're not flaccid. And we want to make sure that there's enough and proper amniotic fluid around the fetus. So the maximum score is 2 points for each one of these 5 parameters. So a score that falls between 8 and 10 is considered normal. So if we do a biophysical profile and this baby scores between 8 and 10, we know this baby is doing well in utero. When we talk about vaccinations during pregnancy, there are some vaccinations that are safe to administer and others that are not because they are live vaccines. So the safe vaccinations that a mom can and are encouraged to get if needed during pregnancy is the Tdap. That's tetanus, diphtheria, and pertussis. So the main thing we're worried about in this vaccine, the main thing that we use this vaccine for is the pertussis. So pertussis is the whooping cough. So an adult can be a carrier of pertussis and be asymptomatic, and it doesn't really affect them. However, in an infant, we all know that whooping cough can be deadly. So just by holding an infant close to your body, and if you're a carrier of pertussis, you can pass that on to the infant, causing them to get whooping cough and get very, very ill and possibly die. So we do recommend that our moms get a Tdap during their pregnancy, or at least right at the initial postpartum stage. She can also get a hepatitis A vaccine if needed, a hepatitis B vaccine, as well as the yearly influenza vaccine. The vaccines that are unsafe during pregnancy is the MMR, which is the measles, mumps, rubella vaccine, and the varicella vaccine, which is the chickenpox. If mom gets tested and finds that she is not immune to any of these, or she's weakly immune, meaning that at one time in her childhood, she received this vaccination, but it has worn off as she's gotten older and she requires a booster. She cannot do this during the pregnancy because these vaccines are live. So in those cases, we would make sure that we were educating our mom to be careful to stay away from anybody who has measles, mumps, rubella, or chickenpox, which can all be detrimental to the fetus, and that we will educate her that once she's delivered, we recommend that she get these booster vaccines while she's there at the postpartum stay. And so oftentimes we are giving that varicella and that MMR booster during those few days that she's on the floor postpartumly, because at that time it's safe, and yes, it is safe for breastfeeding. It's just not safe while she's pregnant. So that is the end of our antepartum lecture. We're now going to move on to high-risk antepartum. Thank you.